Now we will engage in discussion with our panel of experts. We're joined by Alan Karp, the Executive Vice President of Healthcare Management and Transformation at Horizon Blue Cross Blue Shield of New Jersey. Mr. Karp has responsibility for Horizon's healthcare value strategy and clinical and network operations. We're also joined by Dr. Matt Hanley, Interim Regional President and Chief Clinical Officer at SSM Health, where he's working towards transforming SSM Health to a value-based care delivery system. And finally, Dr. Miles Snowden, Chief Operating Officer at Navathe. Dr. Snowden is responsible for clinical operations as well as ongoing in-market delivery of the company's population health solutions. I invite all of our panelists to turn on their cameras and microphones. And to get us started, Alan, can you describe the initiatives at your organization related to value-based care and supporting physicians?
Yes, thank you. Thank you, Catherine, and thank you for having me here with such a great group of panelists. So just a little bit of background on us. We have approximately 60% of our members in value-based programs in all lines of business. We have patient-centered medical home programs with over 4,000 primary care physicians, strategic alliance partnerships with 6 of the largest health systems in New Jersey and their clinically integrated network of physicians. And we have bundled arrangements with about 1,000 specialists. So we have several initiatives that we use to support physicians. The first is an incentive system focused on quality metrics and cost of care targets, data integration and sharing of plan administrative data, and combining that with provider clinical data through a private HIE that we built called HealthSphere. And we also provide analytic support and insights to physicians on medical cost opportunities, variations of care, and quality measures. We've also created a value-based playbook for the physicians, which they, back to what you heard from Amol, they worked with us to build this playbook. So this was a lot of physician input, hospital input, which is important to get buy-in. We created a quality committee, which is made up of clinicians from the physician groups and health systems that we support, along with our clinicians. And that's really important, again, to get their feedback and help us make any course corrections that we need throughout the relationships. And the last thing is the governance structure, which I think is really important to oversee these arrangements. We have governance structures for each of our large groups and health systems where we meet on a regular basis, share information, identify areas where we can improve from a cost and quality perspective and a patient service perspective. And that's really important because it creates the partnership necessary to be able to drive towards the triple aim. So I'll stop there.
Thanks, Matt. How about at SSM Health?
Yeah, thanks, Catherine. Again, delighted to be here. Little high level overview of SSM Health. We're a $9 billion faith-based health system across 4 different states here in the Midwest. We, in addition to a broad-based care delivery, we also have a health plan. So the formerly what's known as the Dean Health Plan cover just under about 500,000 lives across the system, with the predominance being in Wisconsin. And also own a pharmacy benefits manager, Navathe, which is delivers, which helps with the management and delivery of medication through health plans across 50 different states. So fairly diversified portfolio. And then I would say within Wisconsin, there's a uniqueness there in the sense that with the predominance of our health plan lives up there, we have a significant amount of our IDN revenue or premium revenue fully capitated for the work that we do, which is a unique situation. So in terms of how we have, as an organization, positioned ourselves, I would say the first thing is several years ago, we as a leadership group took the position from the top of the organization that we're going to be a value-based care organization, aligned with our mission. think it's easy to say it's just better care. But it's also, I think, consistent with wanting to create a sustainable solution for our nation in terms of a care delivery platform. I think we all have this sense that we're running off the cliff. We have done a number of things to visit our shelves and also, I think, position our clinicians to help lead that charge. So certainly we have engaged in a partnership with NAVIS. NAVIS has been critical in helping us, I would say, catalyze and help build infrastructure and muscle and competency as it relates to doing the things related to value-based care. Because I think when you engage with clinicians, they ask you two different questions. What do I do? And how do I lead? And so there is, and I'm not going to repeat what Alan said, but we've done a lot of the similar things around governance, around data, about putting in specific infrastructure. I think as it relates to specifically the care delivery piece itself, we've been very deliberate about going in and designing workflows as it relates to specifically talking about population and taking care of the populations. I think we've been very deliberate about starting to change the culture with the clinicians. So in other words, how do I actually do this work? It's very different from how we were trained as clinicians coming out. It's a very different care delivery platform. And I think the third thing I would emphasize is being very crystal clear about the problem we're solving for, which to me is defining value, and then specifically telling the clinicians what value means, and then how we're going to measure that. And then the last thing I think Alan also mentioned was incentives. I honestly think that incentives are absolutely critical, and lack of incentives can only sort of get you so far as it relates to engaging the clinicians. And so we have been very purposeful in redesigning our compensation programs, specifically around primary care, but are also looking into the specialty space as well.
Thank you. And Dr. Snowden, Matt just alluded to your role, but why don't you give us a little bit more context and talk about how you're working with these organizations and others across the country? And you're on mute. There you go.
Sorry, I was so careful not to interrupt anyone. I interrupted myself. Thanks, Catherine, and I appreciate the chance to be here, and I so much respect what each of these others have been accomplishing. Amol and his bringing rigor and observation and measurement to population. We very much need Alan to advancing the ball in regard to how payers actually deliver enabling capabilities to their network physicians, which is so important. And then Matt in advancing a massive health system into a whole new way of thinking about serving their community and their ministries. It's such a neat combination of participants in the market. NAVIS is, if you think about what Amol opened this session with, is an organic development out of the secular changes that he described so well. And that is the representation and the understanding that the physicians are an essential ingredient to being successful in managing cohorts or populations of individuals. And we cannot free the physician of participation in that. We can't work around them. We have to lift them up, enable them, and let them lead. And everyone on this session today is working in some way toward that. So NAVIS developed to be able to provide essentially an operating partner role, primarily focused on serving physicians, but at the sponsorship of any of the major stakeholders in the industry. So we have almost an even share right now of sponsorship and partnership and client relationships with payers, health systems, and physician groups. Yet, regardless of which of the three partnerships sponsors our work, our primary focus is on lifting up, enabling, and preparing physicians to lead complicated systems of care into different reimbursement models. So we do this at the behest of each of the different stakeholders, but focus primarily on the physician as the key to success in value-based care. We do that with three principles in mind. The first is win-win. We primarily want to have an exclusive relationship that's highly durable, that allows each of us, both ourselves and our partner, to invest deeply in, with capital, both human and financial, to advance a very complicated process over a very long term. We don't try to distribute a point solution and wish the very best. Secondly, we believe in standing starts as a principle, and that is we want to take what's already deployed and use it to its best and highest purpose. So no rip and replace, represent and understand that which has already been invested and make the best of it. And then last, all in. We fundamentally believe that it is impossible for physicians, physician practices, and systems of care delivery to treat differently contracted patients differently. And so all contracts, all payers, Medicare Advantage, Medicare fee-for-service, commercial, ACOs, all members of the community being served are treated to the same process and procedures. So win-win for all, standing start. Start with what you got and make the best of it, and last, all in, all contracts. And those are the principles we start with on these sorts of partnerships. Thanks, Catherine.
Thank you. Going back to Matt, could you talk about some of the challenges that you face as you've moved to increase levels of risk, and also how COVID-19 either accelerated or complicated the transition?
Yeah, absolutely. Well, I mean, COVID has, I think, been the centerpiece for conversation for the last 18 months. And I think it's been both a gift and also, an opportunity for us all. I think, just practically speaking, I mean, COVID has taken up a lot of our bandwidth. So any dedicated focus on this transition to value-based care has been somewhat consumed by the shift of attention and energy on in terms of how and what we need to do to respond to COVID. And so we're sort of in this yo-yo period where we're hoping this pandemic moves on so we can all focus on the work at hand. It's created distraction with finances. So depending on the type of organization you've had, it's either been the ultimate hedge or it's been the ultimate stressor. I think at SSM we're in the middle ground because we have a diversified set of assets. And then the third is just the fatigue. I don't like the word burnout, but the fatigue has been just intense. So it has been hard and challenging in that aspect. But it has also, I think, allowed for, honestly, as I said, a burning platform. It's allowed us to really crystallize and be singular in our commitment towards knowing that at the other side, the value-based care is the right strategy for us. It has also allowed us to I think many people have experienced I would call it lateral leadership and the collaboration between clinicians that didn't exist in the ways they do today. So when you're singularly focused on solving a problem that is frankly singularly clinical, it is a wonderful way to convene your clinicians, which we have done, and we've been able to sustain and keep some of the operational models we've had in place. That has led to collaboration, it's led to relationships, and it's led to new processes and workflows that will vastly benefit us in the future. And then the last thing I would say, it has also provided us an opportunity to continue to integrate the clinical voice into the operations of the organization, which is, I think, absolutely incredibly important for moving towards value-based care or value-based care delivery, especially at risk. So I think those things have been a gift. And then I think I wouldn't say coming out of COVID, but still being in COVID, I would also say that it has also crystallized the market's demand or focus on total cost of care. And so I think that to me, that voice is as loud as it's ever been. Because of the broad stressor that COVID has put on our economy, and that just affirms that the work we're doing.
Great. Thank you, Matt. Alan, I know you're joining us by phone. What are you seeing in New Jersey?
Well, so first, I agree with everything Matt said. I thought he laid it out well. What we've learned, and we have about 350,000 of our members under risk today. We're expecting to be around 1 million by 2024. But one of the first things we learned is we have to get the leadership from providers, whether it's physician leadership or health system leadership in our case, comfortable with moving first from fee-for-service to value-based reimbursement and then for risk. So our approach was to start with what we call a pathway to risk, which moves the providers to shared savings initially to get away from completely fee-for-service reimbursement, and then get them comfortable with the new model. And part of it is getting them to understand the financial opportunities under the new model, but more importantly, the impact that it has on patients if we're working together. The other thing we're able to do is to limit the downside risk for the first year for our partners by offering reinsurance and other ways to limit that risk. And as the years go by, they expand the risk profile on the downside with us. And the last thing is it helps with the physicians in that we are delegating more of our services down to the physician and clinical level where they belong, so they can make those decisions and lift some of the burden that they typically feel and the additional stressors associated with things like, calling for authorizations and some of the other administrative challenges that they have with payers. So that's been big. And again, the patient care model allows the physicians to spend more time with patients and allows us as a payer to focus on things we do well, data analytics, and some of the other things we can bring to the table.
Thank you. Amol, what are you seeing from an industry perspective and your research?
Yeah, I think I would echo a lot of the themes that Matt and Alan mentioned. There's obviously a lot of moving parts at play in the shift from a volume-based system to a value-based system. And what we've seen, so for example, through work that we've done with the Blue Cross Blue Shield plan in Hawaii in instituting a primary care payment system, a new primary care payment system that was heavily based on population-based payments or PCP capitation. There's a variety of kind of baseline capability that you start with. Some practices, in fact, are really high functioning practices. They're just really high functioning for fee for service, right? Because that's the system that they're optimized in. Others are exposed to multiple different types of payment mechanisms, and so they found a way to straddle that. And so shifting those systems, oftentimes there have been years or maybe even decades of investments that have gone into that optimization. So I think we have to be realistic about what that means in terms of a change over time. We have to catalyze the right type of investment, and we have to make what I would consider longer term commitments. And I think the group that's on this panel, of course, has a lot of experience doing that. But unless you have a 5-7+ year horizon, it's often very hard as a physician group or a health system to find those dollars to say, look, we can invest this in the correct way. And COVID obviously has complicated a lot of pieces around the finances. I mean, it has created a lot of uncertainty, which, I agree with Matt's point that this has been an accelerant in some way in thinking about, getting to fixed type of global budget models, total cost of care models, capitation-based models. These are all ways to mitigate some of that type of uncertainty. But we've also seen the pendulum start to swing back. So for example, early in the pandemic, we saw elective surgeries, some of which were definitely necessary, some of which probably were low value. We've seen that resurge in the past several months. So a lot of that elective care has come back. The telehealth pendulum, obviously it swung really far in the early part of 2020 to the summer of 2020. We've started to see that pendulum swing back. I would say in our local market here in Philadelphia, for example, now only about 10 to 15% of what it used to be, at its peak. Not saying the peak was perfect, but just as an indicator that pendulum can swing. So I think, it's incumbent upon us as healthcare leaders, as clinicians on the ground to say, look, we're going to embrace the good things that happened, again, as Matt highlighted, of the pandemic to try to preserve those things because those are actually good for our patients, while of course working on the parts that are more challenging about the pandemic.
So, Dr. Snowden, how do you create this value-based care culture, especially thinking maybe pre-pandemic, post-pandemic too, with everything that's happening? And what are some of the key strategies for aligning payers and physicians?
Sure, thanks, Catherine. So my observation is that I consistently see two things that are in short supply that I consider to be the fuel for transitioning to value-based reimbursement. One is capital and one is scale. And that, I think, is why it's so critical that our commercial payers, such as Allen and Horizon and others that were mentioned by Amol earlier and many others, that they participate in and they foster these sorts of transitions, and also large health systems like Matt's foster these sort of transitions to provide capital. And I'll get to scale just in a moment, but to stay with the capital for a minute, I think the ability to leverage existing payer contracts and foregone upside opportunity in those value-based contracts that are already executed and sitting on the shelf provides some of the capital necessary to make this transition, which is why my observation on COVID was there was no pause in the interest to moving to value-based reimbursement. I saw no one any less interested, recognizing and respecting, of course, the severity of the pandemic, its effect, but there was still high interest in being able to advance the financial ball in regard to gaining some opportunity on the foregone gain sharing opportunities. Our own analysis is that about 70% of ACOs leave dollars on the table. So if you just improve your performance, you leverage those dollars that you were foregoing, and then you reinvest those into your program to create more capital and move forward in investing in technology, new people doing new processes, more people doing new processes, new analytics, new data, then you have the ability to self-fund to some degree your transition. Scale is the second item I mentioned as a fuel for value-based reimbursement pivots. What I mean by scale is the reason smaller physician groups are not very successful in this change is they are trying to continue that fee-for-service reimbursement model because they don't have a capital process. They're not allocating capital each year to the next year's needs. And so they have to maintain the fee-for-service cash flow to fund what is actually a long tail on a reimbursement model for value-based reimbursement. And the two don't jive. You can't have a cash-based business that needs to invest in a long tail reimbursement on a different model. So it requires getting to scale quickly, meaning bringing more of your patients into value-based reimbursement models as quickly as possible. And so concerted efforts to move as many of your patients prudently to value-based reimbursement models, moving up the risk continuum gradually, and finding a capital partner or a source of capital through foregone gain sharing and existing contracts. Those are the two things that I feel like are first steps in this process. And for these reasons, really no reduction in interest over this past year to year and a half.
Alan, how were you creating this value-based culture among the physicians that you're working with through Horizon? Alan, are you still with us? You might be muted.
I was, I'm sorry. Thank you, Catherine. Sorry about that. First of all, I agree with everything that I just heard from Miles. But for us, it starts with, again, the buy-in from the leadership, physician leadership and leadership from the top to begin to build that culture. And we, again, we do that by getting them involved in understanding the models and understanding the opportunities, and understanding the difference in a value-based culture than in a fee-for-service culture. We use data and analytics to show them data and get them to understand where opportunities are, as I said earlier. We take a lot of time on aligned incentives to make sure we have it right, both from a cost and quality perspective. And then we work very closely with them to make sure that we are cultivating that culture where the view is on managing populations as opposed to just seeing patients in the office. And that really has been a big win for us, because, you know, if most physicians have their way, they want to spend time with their patients. And then last but not least, a governance structure that meets continually, that continues to reinforce certain behaviors. That's really important when it comes to the new culture that we're trying to build. So those are some things we've done in addition to what you heard from Miles.
Thanks. Matt, what is your experience with SSM Health?
Yeah, so first of all, I really appreciate the previous comments, and the one on capital and scale, I think is absolutely salient. You know, I think for us, you know, as I said before, I think it's, you know, first and foremost is being very crystal clear about the problem we're solving, you know, and being crystal clear with the clinicians and what your specific definition of value is. And I'll say, you know, I think the problem we're solving, and not to be trite, is total cost of care. You know, you may say, because I'm a clinician, it's a little bit of a heretic statement, but I do believe that until, you know, that decisions are made on cost these days, quality is assumed and experience is desired. And I also believe that if we pursue total cost of care the right way, we'll deliver the right quality outcomes and we'll deliver the right experience and access for our patients. So I think it's being crystal clear about that. And then I think you know, for us, the three ways that we're engaging them, the clinicians, are one, through an innovative care model redesign. And I think, you know, we all can do supply chain, we can all do FDEs, we can all do cost management structure, we can all do scale as well. But at the end of the day, I think we're still left with care model, you know, redesign. We have to fundamentally, as I think Amol referred to, is take care of patients. They're fundamentally different in a way that does drive down that total cost. So can we do infusions at home instead of a provider-based billing? And so on and so forth. Can we take care of more patients at home instead of the hospital? And that's the crux of I think what we're doing. We have to be able to turn to our patients and say, hey, this is a better value product this year than it was last year. The second is the culture and the communication with the clinicians. So, I mean, we've talked about that, but again, the clinicians are asking the question, what do I do? So they want to understand the competencies and the expertise. How do I redesign care? I wasn't taught that in med school or residency. What does a care management structure look like, and how does that integrate into my practice? What does it mean to be at risk for payments? And then how do I lead? How do I lead my colleagues and my teammates in this direction when I was taught to lead them in another direction? And then the last thing, we've said it again and again, but I do believe the incentive piece is so very important. And so when we look at you know, clinicians who are fundamentally incented for at-risk payments have different just different behaviors as it relates to care delivery than if you're incented in fee-for-service. And I just think that's, you know, normal human behavior, right? And I think we have to sort of pay attention to that. So for us, being very innovative, but also very aggressive to align our incentive compensation structures with the clinicians. And then I would also add that in addition to the clinicians, we have to incent the rest of the system as well. So within the entire ecosystem, how your hospital presidents, for example, get incented is important. So thank you.
Thank you. Amol, would you like to add anything based on your experience working with payers and health systems?
Sure. I mean, so I definitely agree with the preceding comments, and I would say, wow, how great would it be to have a leader like Matt driving change in every health system and physician practice across the country, right? Who's totally embraced the value-based paradigm and thinking about, getting all the different nuts and bolts and pieces to drive that. So I think that's a reflection, one, obviously that Matt's a dynamic leader, but also that it can be done, right? It just absolutely can be done. And I think there's a couple of additional things to highlight here, right? So first off, we have to recognize that physicians are different than other skilled workers, if you will, across other industries, because we give physicians a lot of autonomy. I myself am a practicing physician. At the point of care, right, I'm the expert because I'm the one who's working with this patient. I know that family, I know their values. So we have to find a way to influence physicians while still giving them the autonomy to spread their wings and really own the patient. If we take that autonomy away, it's not going to work, right? It's just totally not going to work. And I highlighted this, in fact, in a Harvard Business Review article for anybody who's interested, happy to share. I think that it's just fundamentally different in the healthcare industry with physicians in particular than other, sort of analogs, if you will. And I think that means sort of a couple of things. One, we have to get early buy-in. We have to engage them in the process. And this ultimately has to be done starting with the physician in some sense, right? This is kind of a bottoms-up approach. We have to start with the rank and file practicing physician and generate culture change at that level and drive it upwards, rather than thinking about it as a totally top-down approach. And I think incentives, for example, really do matter. I would pair with at this point that we have to make it about the patient, right? Because most of us who've gone into healthcare in any role, we're doing it from an intrinsic motivation that we really want to help our patients. And so if we can make that the centerpiece of why we're engaging, much as the way that Matt said, right? We have to redesign our system because it's the right thing for patients. If we start there and then follow on with the transparency principles and the other pieces of alignment, I think we can build that culture and drive a lot more change.
Great. We have a couple more minutes before we go into Q&A. So wanted to ask each of you, for executives who are looking to move their value-based care initiatives from deployment to scalable enterprise class performance, what advice would you give? Miles, do you want to start?
Sure, I'll start, but I am so focused on what was just said by everyone that I have to just bridge all that if I might. But perhaps I'll use that as my answer. And my answer is that we need, as an industry, to recognize and provide for the fact that, as Amol said, physicians are largely mission-based. They get their training not in white ivory towers of research, but rather in municipal and county hospitals, VA centers, seeing patients who often are in a great deal of difficulty. And you don't forget that, and you don't quit planning to serve that. And we need to respect the fact that physicians don't do population health. They see patients, have to see patients one at a time, sequentially. There is no other way to deliver healthcare. And so if we respect that fact that medicine is delivered one at a time, and then surround that with that respect, and then build the infrastructure that allows the one-on-one patient care to be delivered while potentiating the impact of that across the population that has been attributed to that physician, then we're making some headway there. So we do that with respect for the art of medicine. Sounds naive of me to say it, but I still believe it to be true. And with a value proposition that must be built and must be articulated well, that says to physicians, this is why this transition will make your practice of medicine more sustainable, more enjoyable over your career, and more rewarding in the broadest sense. In whatever way intrinsically you are rewarded, that you will experience that to a higher level. And those are the sorts of things that is the art of this transition. I feel that we focus too much on technology point solutions and less about the culture of change and how we build the value proposition for those most impacted by this, other than patients. Thanks.
Thank you. Dr. Hanley?
You gave me a little more time than Miles to think up. No, it's a great question. A couple thoughts. I think, you got to land on your definition of value. Doesn't have to be complicated, but you have to fundamentally define that. I think it's important to think about the recognition that you have to engage the entire ecosystem. So I think up to this point, there have been a lot of individual players who've come into the market, focused on maybe primary care, focused on a single payer, focused on a certain part of the care continuum, maybe post-acute, as they look to get in value-based care. And all those are great, but at the end of the day, it's the entire ecosystem of healthcare that has to be knitted together. So I think it's important to think about, to have that concept of mind. How are you changing care across the entire continuum? We've mentioned alignment of all the incentives. Maybe the last thing is playing off what Miles said, is that this is fundamentally, it's a clinical care delivery transformation. I mean, like I said, there's going to be a lot of mechanics around payers and finances and scale and capital, but the underpinning of that is we have to fundamentally change the way we're taking care of patients. And so the integration of the clinical voice, the clinical leaders into the fabric of the operations of the organization is absolutely critical for that.
Alan, are you still with us?
Yes, I am. I would say, if I was giving advice, start now if you haven't started already, because it does take patience. It's a journey, not a sprint. It takes a while to get everybody aligned and physicians aligned in what you're trying to accomplish. I think, obviously, the definition of value, as Matt said, is important. I would also say a strong business case for moving from fee-for-service to fee-for-value. What I mean by that is focus on total cost of care, why that's important. Look at the delivery system, reevaluate what the processes are that we're using today versus what we should be thinking about. Again, data and strong analytic capability is important. And then last point would be measure what matters. I mean, sometimes we try to boil the ocean. I think focusing on the things that are important to actually change the culture and change the way care is delivered in finance is really critical.
Amol?
Yeah, I have 4 words: start small, think big. And what I mean by that is start small, start in the micro way. Think about this starting with an individual patient, an individual physician. As Matt and others have said, think about the individual metrics and the processes that we have to change, right? Start small. Think big, because you're trying to drive big transformation. So you're not going to have all the capabilities likely. You're most likely going to need some capital. You're most likely going to need partners to make this journey possible. So I would say start small, think big.